Now let's talk chronic obstructive pulmonary disease, or COPD. COPD comes in a couple flavors. One is chronic bronchitis. You got patients with chronic bronchitis, and probably more commonly emphysema. So we've got patients with either chronic bronchitis or emphysema. With COPD, we've got this trilogy of symptoms and just kind of pathophysiology. One is bronchoconstriction. It's the first part of the trilogy. So all of our COPD patients have bronchoconstriction, and this is chronic bronchoconstriction. All of our COPD patients have chronic mucus production, and then all of our patients have chronic atelectasis. So our COPD patients have atelectasis, which is just a hardening of our alveoli. So they should be nice and pliable and um, kind of inflate, deflate with our surfactant kind of normally, but with atelectasis they have a surfactant is kind of dried up, and now they've hardened. Well, wait. So we said emphysema and chronic bronchitis, but asthma is also it causes bronchoconstriction. Asthma also causes mucus production. So is asthma a COPD, a chronic obstructive pulmonary disease? Well, yes, it is. Asthma is a COPD, but no, asthma is not a COPD. So we don't classify asthma as a COPD or asthma within the COPD family because the obstruction is reversible. People live with asthma, but it is exacerbated, so they're not in an asthmatic state every single minute of every single day, just like our emphysema patients are. So they will have this obstruction, they'll have this bronchoconstriction, this mucus production in acute settings and acute episodes, but it's reversible. Our emphysema patients, this isn't reversible. We can manage the symptoms, we can manage the exacerbations when they happen, but they're still going to be bronchoconstricted. They're still going to have mucus production. They're still going to have atelectasis. So, is asthma a COPD? Kind of yes, mostly no. It just doesn't kind of quite fit into that family because that obstruction is reversible. So back to our real COPDs, our chronic bronchitis and our emphysema. Under bronchitis, our chronic bronchitis, we've got that mucus production, and we've got endothelium damage. So you've got a lot of bacteria in there. We just can't clear them out. We can't clean them out. And once you get into that pulmonary capillary bed where we have exchange of oxygen and carbon dioxide, the pulmonary capillary bed is actually undamaged. We have endothelial damage within our bronchioles, but we don't have pulmonary capillary bed damage. And this is where we get into the distinction between chronic bronchitis and emphysema. With emphysema, we do have destruction of that capillary bed, leading to pulmonary hypertensions, leading to right ventricular failures, and destruction of our alveoli. So with our chronic bronchitis, we have endothelial damage, which is bad enough as is. We still have the mucus production with bronchitis and emphysema, but with bronchitis, the capillary beds are still intact. They're undamaged. With emphysema, capillary beds are damaged, so we have even less oxygen, carbon dioxide transfer and SWIP swapping. And then our emphysemas lead to pulmonary hypertension, pulmonary problems, or pulmonary circulation problems, and right ventricular problems. Signs and symptoms of our COPD patients. We're going to have wheezing just like our asthma patients, except our asthma patients, this is going to be acute. They're not walking around with it every day. Our COPD patients might be walking around with wheezing every single day with exacerbation, which is when we're going to get called out. The wheezing is going to get worse, work its way into rhonchi, and just like some junky sounds in the lungs. And there's really no better way to describe those sounds other than just like junky, kind of chunky, gunky sounds in the lungs. Your patients are going to experience weight loss when they develop COPD and these chronic issues. They will develop weight loss. And then this kind of barrel chest. So this hyperinflation, our COPD patients, just like our asthma patients, are trapping air inside the lungs. There's a big issue with this um, bronchial inflammation of releasing air. So exhalation is a big issue with these patients. With our asthma patients, it's an acute issue. We can resolve it pretty quickly, and they'll return to normal. Our COPD patients, these are chronic, and they are chronically trapping air. So we've got hyperinflation, and we've got this barrel chest. So if you look at these patients, their chest is kind of just puffed out without without muscle definition or anything like that. This patient going to the gym or anything like that. It's just this large kind of puffed out barrel chest is what you'll see. Our VQ ratio for our COPD patients can be less than 1 because remember our lungs are perfused. There's no issue with circulation. Blood is going round and round our alveoli just fine. There's no pulmonary embolism. There's no blockage in the system, but we're just not ventilated. We're not moving air in and out quite as well as we should. So there's a lot of CO2 retention, right? So that's contributing to that barrel chest. It's a lot of air retention, and we're retaining a lot of CO2. So when we're thinking about VQ ratios, less than 1 COPD, our lungs are perfused, but they're not ventilated. So let's talk real quick some special considerations for COPD patients. One of those is SpO2. So we're going to throw all of our patients, respiratory or not, probably on SpO2, that little probe on your finger. Well, in our COPD patients, let's take that with a grain of salt. So our COPD patients are really, really chronic COPD patients. We're thinking, mild hypoxia is less than 94%, but they might be, bumping along at 93%, and that is perfectly fine for them. So we need to take our patient assessment into account and whether or not we should be, overloading them with oxygen. If they're at 94%, 95%, if I've got a chronic COPD patient and he's at 94%, I am happy as a clam right there. And, I might really continue his home oxygen at 2 liters per minute, and that's about it. So your SpO2, it's a tool, but let's use it, as a tool and as a part of our overall assessment. In our COPD patient, once we get below 90%, we should start worrying, right? So some exacerbation is starting to happen. And our SpO2 is not really going to be super useful in predicting, acute changes. It's just another tool in this case. So in a lot of our patients, SpO2 is a wonderful tool. But with our COPD patients, SpO2 as a diagnostic instrument is not super helpful. Another tool in our arsenal is our EKG, and some of this stuff, or really all of this stuff, we're going to talk about more in our 12-lead course. In the fall, we'll really kind of dig deeper into this, but with our ECGs or EKGs in COPD, everything's going to be to the right. So we're talking about right axis deviation, we've got right bundle branch blocks, we've got right ventricular hypertrophy, we've got right ventricular strain patterns. So we're talking respiratory, we're talking pulmonary system, and if we're kind of logically backing things up from the heart, where do they go? If we back up from the right side, the right atrium, right ventricle, where do we go? We go into the pulmonary system, that's respiratory. So any of our respiratory issues are going to cause right atrial, right ventricular issues. And again, we're not going to dig into these right now. We'll dig into them in the fall when you take our 12-lead course. So what are we going to do for our COPD patients? Again, let's start with oxygen, right? So we've got oxygen, oxygen, oxygen. Increase their FiO2, their fraction of inspired oxygen from room air, up to a non-rebreather at 98-ish%. But that's not going to kind of really cure them, right? Because we've got on that VQ ratio issue, we've got a ventilation issue, we've got an issue of air movement, so we can pour in as much oxygen as we'd like, as we want, but we need to open up those airways. So our beta agonists, our albuterols, in the short term, are going to help us a lot. Our anticholinergics, our Atrovents, our ipratropium is going to help us a lot. So we can do a DUNEB, we can do Atrovent and albuterol together. So your albuterol bronchodilating, hopefully our Atrovent as an anticholinergic, hopefully drying out that mucus production, and we can hit them with some methylprednisolone or solumedrol, which is a steroidal anti-inflammatory. If you have any questions, comments, concerns, or cuss words, please let me know.